Bien, bueno, ahora sí, hola a todos, buenas noches, es un gusto saludarlos y darles la bienvenida. Yo soy Félix Suárez, editor en jefe de Editorial Amolca, y esta noche tengo el gusto de presentar a un referente en el ámbito de la laringología en el mundo, que estará a cargo del seminario que hemos titulado Fonomicrocirugía para lesiones de las cuerdas vocales. Saludo al doctor Clark Rosen. Dr. Rosen, welcome to this webinar. How are you?
I'm doing great. Thank you for having me.
Thank you, Doctor. It is a pleasure and an honor to have you with us today. Many professionals have registered for this event, and we are very pleased to have the opportunity to listen to you and share this time with you. Thank you very much for accepting our invitation, Doctor. Y bueno, yo también quiero darle la bienvenida a la doctora Antonia Lagos Villaseca, que muy amablemente aceptó también nuestra invitación para participar en este seminario en calidad de interlocutora del doctor Rosen. La saludo también, doctora Lagos. ¿Cómo está usted? No la veo por allí.
Hola, buenas noches, un gusto. Gracias por la invitación.
No, bueno, gracias a usted, doctora, de verdad. Bueno, agradezco también a todos los asistentes de hoy por tener el interés de escuchar al doctor Rosen y por dedicar un poco de su tiempo para estar aquí con nosotros. Y bueno, no quiero extenderme mucho con esta introducción. Yo voy primero a explicar cómo estará organizado este seminario. En primer lugar, leeré una breve semblanza profesional de nuestro invitado de hoy, de nuestros invitados de hoy. Luego les daré la palabra bueno, le daré la palabra al doctor Rosen. Durante la presentación, los asistentes de este evento pueden ir haciendo sus preguntas a través del chat que está disponible en esta sala y después de la exposición del doctor Rosen, la doctora Lagos leerá las preguntas que ustedes puedan hacer y traducirá las respuestas para el público. Yo, bueno, quiero hacer una acotación. El doctor Simpson, que es coautor de la obra Técnicas quirúrgicas en laringología con el doctor Rosen, había sido invitado hoy, pero lamentablemente no puede acompañarnos. Igualmente, bueno, ojalá que pueda ver este seminario y le mando un saludo cordial al doctor Simpson. Y bueno, yo quiero pues entonces, bueno, leer un poco e introducir al doctor Clark Rosen, quien es codirector del Centro de la Voz y la Deglución de la UCSF, jefe de la División de Laringología, profesor de otorrinolaringología y cirugía de cabeza y cuello, y titular de la cátedra Louis Morrison de laringología. Es autor de más de 300 publicaciones revisadas por pares, 38 capítulos de libros y 8 libros. Además, es autor de Técnicas quirúrgicas en laringología, en su primera y segunda edición, ambas editadas y publicadas en español por Editorial Amolca. El doctor Rosen ha sido reconocido por la AAOHNS con 3 premios al servicio distinguido, ha recibido una mención presidencial de la ALA y el premio a la excelencia en la tutoría para el profesorado de la UCSF. También recibió el premio Chevalier Q. Jackson de la ABEA en el 2024 y además impartió la conferencia Baker en la ALA en 2025. Bueno, quiero presentar también a la doctora Antonia Lagos Villaseca, médico con un fellowship en laringología por la McGill University y profesora asistente del Departamento de Otorrinolaringología de la Pontificia Universidad Católica de Chile. La doctora Lagos completó el diplomado de laringología de la Universidad Nacional Autónoma de México, una estadía de investigación y observership en la Universidad de California, San Francisco, y un fellowship en laringología en la McGill University en Canadá. Es fellow internacional de la American Laryngological Association y active fellow de la Theological Society. Su práctica clínica e investigación se centran en patologías de la voz. Y bueno, ahora sí, después de esta introducción, de verdad, doctora Lagos, muchísimas gracias. Thank you, Dr. Rosen, for accepting our invitation. Le cedo la palabra al Dr. Rosen. Dr. Rosen, thank you. Somos todo oídos. The floor is yours.
Thank you so much. On behalf of my co-author Blake Simpson and myself, I'm excited to have a small talk about a very small part of our textbook, something that's near and dear to most voice-loving otolaryngologists or laryngologists, and that is vocal fold lesions of the surgery for vocal fold lesions. So I'm going to relatively quickly walk you through 2 or 3 important topics regarding phonomicrosurgery. All of these topics and much more are covered in the second edition of Operative Techniques in Laryngology. And now, thanks to Amolca, the book has been translated into Spanish, which I think is hopefully going to be a great resource for everybody. I just had a visiting ear, nose, and throat doctor with me from Mexico over the last month. And when I told him that the book was in Spanish, he's like, "Oh, I wish I knew that. I bought the English version, and it would have been so much easier if I knew that it had been translated in Spanish." So I'm very grateful for the everybody that took part in translating the book, especially Dr. Antonia Lagos, who has been a huge help in obtaining the book to be translated in Spanish. So as I said, we're going to talk about phonomicrosurgery of vocal fold lesions. This is a brief overview. There is much, much more that I don't have time to talk about, but I hope that this is helpful to everybody, and I'm looking forward to answering questions as we go forward. So let's see if I can move. There we go. These are my disclosures. And this is the 2 editions of Operative Techniques in Laryngology from the English version. The artwork, the educational material of this book, I think is really, really special. In the 2nd edition, we've expanded the book significantly. We've added a lot of more newer surgical techniques, including a gender-affirming care, surgery for dysphagia care, and there is also a editorial component to the book now, where there's a second opinion giving a different expert's opinion on most of the chapters, and I find that being very grateful and helpful to the readers to hear several different opinions on how to approach a surgery. So today I'm going to talk a little bit about vocal fold lesion nomenclature, and then I'm going to talk about microflap surgery and give a bunch of different case examples, and then we'll have hopefully time for questions and answers depending on how much I talk and how quickly I go. So just to get everybody excited about what we're doing, I thought I would show kind of a typical type of patient who has a lesion and needs surgery for this. So here's a patient I saw a good number of years ago.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. Sore throat, raspy voice. It's been really bad since December. One more time. Hold that out. Right, we're done.
So this woman's a school teacher. She was unable to keep using her voice throughout the whole day, and especially towards the end of the week, she was really struggling. So she went through voice therapy and still had some needed to move forward. And so here you can see what her VHI-10 was before voice therapy and then after. So it didn't help her too much, from 33 to 29. And so then, there's lots of questions. We're not going to slow down and talk about too much, but of course, what's the diagnosis? What are our treatment options? And those types of things. So no surprise, since we're going to talk about surgery, this patient needed surgery. So here's a video of her at the very first part of her phonomicrosurgical procedure, where I'm just palpating the vocal folds bimanually with a couple curved elevators, getting a sense of what is the nature and appearance of this lesion.
Now.
Very good. So this is how I like to start each one of my procedures. After I've looked at the at the larynx with the 30 and 70 degree telescope, under high-powered microlaryngoscopy, I like to palpate the vocal folds, understand exactly where the pathology is. Is it subepithelial? Is it underneath the free edge? What's involved? What's not involved? How does the mucosa look? There's lots of things that are going on during this initial evaluation. And so, the big question is, what do you do with this lesion? Do you strip the vocal fold? The answer is no. Could you use a laser, CO2 or KTP? You could, in theory. I'm not a fan of any type of laser surgical procedure for benign lesions like this. And do you treat the contralateral lesion? Do you need voice rest? So lots of questions, but I'm going to keep moving on. This is just a kind of a whet your appetite type of thing. And so she underwent a microflap excision, which I'll show you a lot more details of shortly. And this is her 6 weeks after surgery. And she had, once we opened up her vocal fold, it was clear, you could get a sense of it. She had a subepithelial cyst. And I'll give you the specific diagnosis of what I mean by subepithelial cyst in just a handful of slides in a minute.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
So how have you been doing since your last visit?
I've been doing great.
When was your surgery?
6 weeks ago.
This is your first visit back?
No, it's my second. I think this is my discharge day.
How has your voice been since?
Since the surgery, it's been wonderful. It's been great. I now have a voice, whereas before I didn't.
Beep. And a high pitch beep.
So she's still a little stiff, but she sounds pretty darn good. For 6 weeks out, she's probably in good shape. And it's always a good sign when your patients say, I don't need to come back anymore. That means they're happy with their voice, and that's a good thing. So what we're going to talk about today is phonomicrosurgery. Everybody has a different terminology for this. The overall concept of phonosurgery is elective surgery to improve the voice. That can be done with microsurgery of the vocal folds, which is what we're going to talk about today. There's many other examples of that: vocal fold injection, laryngeal framework surgery, thyroplasty, retinoid reduction, and another shameless plug. All of those surgical procedures that we're not going to talk about today are covered in the book in great detail. And so if you're interested in learning more about those procedures, or at least having a reference point before you start do your next one, the book's a great place to start. And this is the holy grail for me. I could spend an hour on just this photograph. The key component to this photograph is the surgical procedure is dissected out the subepithelial pathology and is going to preserve the normal overlying epithelium, the microflap that's being retracted. And we're going to talk about how to do that, and I'll show you a whole bunch of examples today on how do we get there. Phonomicrosurgery has had significant advances over the last 10 to 20 years. I always equate this as now similar to stapes surgery in instrumentation and level of precision and outcomes as well. So just a brief overview, we're talking about general anesthesia, microsurgery of the vocal folds for lesions like a polyp, cyst, fibrous mass, reactive lesion, Ranke's edema, not nodules, as I'll explain in just a minute. There's more advanced techniques using these principles for vocal fold reconstruction, for sulcus vocalis and scar, which we're not going to talk about today, but are covered in the operative techniques of laryngology. So let's transition to the question about what do we call these bumps, lumps and bumps of the vocal folds. The biggest problem we have is that we don't have a common language to describe lesions of the vocal folds. I've been working for the last 10 plus years to try to develop that, and I'll share with you our system that we use. It's not the only system, so if you have a system, that's fine, but I wanted to share with you kind of how our thought process is and I would say a whole group of us have been working on trying to standardize the nomenclature for vocal fold lesions. And this is our problem. We don't have a common language. So when we all see this picture, we know it's a horse. We see this picture, we know it's a zebra. But when we see this picture or when we see this picture, lots of times people use different names for this same thing. Years ago, I sat down and wrote down all the names that I've seen in the literature about benign mid-membranous focal fold lesions. And this is an example of kind of names that I've seen in the literature that sadly, none of them are really defined. There's articles on top of articles with all these words in it, but none of them are really defined. So we're not exactly sure what the authors are talking about and what they're not. And so I started a quest to try to come up with a defined, unifying nomenclature system. And this is what I'm going to share with you for the next couple minutes. What we're talking about in this nomenclature system are benign lesions, normal overlying epithelium, mid-membranous, not gigantic lesions, and they're all chronic, not acute lesions. So it's nothing like this. And so this is the first publication that came out of this, and you can see there's a bunch of different authors on this project that are from a variety of spectrums of laryngologic schools of thought or camps, if you will, in the United States. And so we got together and said, how can we come up with a system that describes the majority of lesions that we see at our office? And that's that publication, and you can see the citation at the bottom of the screen if you want to read more about this. The first thing we said is you don't have to make the diagnosis or give a label in the office. And that's so important. I've written it second time. The next thing is we said, let's differentiate and describe the nature of the lesion. We know it's all mid-membranous focal fold lesions. It's stable. It's not acute, not inflammatory. And then let's look at the stroboscopic features. Let's describe if the lesion gets better with voice therapy. And then let's also use the intraoperative findings to make a final categorization of these lesions. And so I'm going to walk you through this. With respect to the anatomy, what we wanted to talk about is we described all these lesions in two anatomic locations. Either the lesion's in a subepithelial space, or the lesion is adherent or adjacent to the ligaments. And so that's what these two red dots show here. And so we'll divide all lesions into these two anatomic locations. So as I go through the descriptors of the lesions, and I talk about either subepithelial or ligamentous, now you know what I'm talking about. We next talked about the physical features of the lesions. Is it a cyst? Is it an amorphous material? Is it gelatinous? And so you'll see those words in our descriptors of our lesions. The first lesion that we defined are called vocal fold nodules. We all are familiar with this term, but the definitions are often different. Our definition is, by definition, they're always bilateral. Typically, the mucosal wave on stroboscopy is good to normal. And by definition, vocal fold nodules go away with voice therapy. If the lesions don't go away with voice therapy, then also by definition, they're not vocal fold nodules. And that may throw people off because they've been using the term nodules or nodule or node. It's what singers like to use it in a different way, and that's okay, but that's not how we're using the word vocal fold nodules in our nomenclature system. Next is a vocal fold polyp, which can be unilateral and bilateral. The definition of a vocal fold polyp typically is normal mucosal wave, does not get better with voice therapy, and then at surgery you'll find a gelatinous accumulation of material in the subepithelial space. The overlying epithelium is usually thin and atrophic and relatively severely abnormal. Of course, the lesion can be hemorrhagic as well. I don't treat anything differently if it's a translucent or a clear polyp versus a hemorrhagic polyp. So I tend not to use the term hemorrhagic polyp because it doesn't change what I do or how I approach the patient. And then vocal fold cyst is quite easy. We find vocal fold cysts that can be in the subepithelial space or on the ligament. So those are two different types of lesions. It could be unilateral, bilateral. Typically, when the cyst is on the ligament, the mucosal wave is quite severe or impaired. And when it's in the subepithelial space, it is more retained. The mucosal wave is retained. These patients typically don't respond to voice therapy. And when it's in the ligament, the cyst is often attached to the ligament. When the cyst is at the ligament, it's usually attached to the ligament with some fibrous tissue that has to be removed. We created a new name to describe a lesion that we all take care of, and we use the terminology of fibrous mass. Fibrous mass is a unorganized aggregation of scar tissue, essentially. And it can be in the subepithelial space or the ligament. It can be unilateral or bilateral. It typically impairs the mucosal wave very significantly, does not get better with voice therapy, and at surgery, you see this amorphous material. So here's an example of a microflap that I've elevated, and I've started to dissect out this subepithelial fibrous mass, which is usually white and thick and difficult to remove. And so that's two different lesions, subepithelial and ligamentous fibrous mass. And then there's a lot of debate about when you have two lesions, is one a polyp, cyst, or fibrous mass, and the other a reactive lesion. And so we, have this term that we call reactive lesion, which is thought to be like a callus in response to the original lesion. Nobody could ever prove that. Typically, this lesion will get better with voice therapy. And there's often what we call a cup and saucer correlation of the primary lesion versus the reactive lesion. And then there's another lesion that we wanted to describe called the pseudocyst. This is slightly controversial, but our definition of a pseudocyst is it's a unilateral fluid-filled lesion, very superficial, and it's typically or always associated with some underlying glottal insufficiency, most often a paralysis or a scar or a paresis. These will not get better with voice therapy. They usually will require surgical excision and or treatment of the underlying glottal insufficiency. Other laryngologists will use the term pseudocyst to describe terminology that we use for vocal fold polyps. So if you read the literature or the articles that have been published out of Cornell by Lucian Sulika, his definition of a pseudocyst is my definition of a vocal fold polyp. They're very similar lesions, and so when you analyze the results of them, the results are quite similar. And then the last lesion I wanted to just to talk about is what's called a non-specific vocal fold lesion. These are a very interesting group of lesions where the patient's dysphonia has resolved after voice therapy, but the lesion still persists. And so that's what we call a non-specific vocal fold lesion. So here's the list of our nomenclature system for these lesions. And obviously for vocal fold nodules and a non-specific vocal fold lesion, those patients do not require surgery. We also had a hypothesis that lesions that involve the ligament, like a vocal fold cyst or a fibrous mass, have a more serious prognosis with respect to outcome, vocal recovery outcome. And we showed that in an outcome paper that we published a handful of years ago. The first author's name is Akbulut. So I encourage you to read that. So here's our transition slide. So we're going to transition from nomenclature to microflap surgery. And so here's a case just to get you further excited about doing this type of work. So here's a 50-year-old male, very successful professional pop and rock singer. I can almost guarantee you've heard his music because he's a worldwide successful singer, has several Grammys, and he came to me with struggling with his voice. Voice rest did not help. He's had some speech pathology services by another institution, didn't help him either. Very compliant. Of course, he's very motivated, given how successful he is. Not a smoker, not really a drinker, no past medical history of note. And here's his patient-reported outcome measures, singing VHI-10 of 17. Nothing else of real note. And here's his voice.
Just tell us again, we just talked about it, but a little bit about what you've noticed in your singing voice and struggles you're having. Describe it for us, if you don't mind.
It seems like my voice is fatigued more than it used to get, and I need warm up to perform efficiently, and my voice is currently unreliable.
Okay, perfect. So let's take a look. He's a little bit of a tough exam, but let's take a look at his exam and see what's going on.
Right there, perfect. One more time.
So it's a, oops, I didn't mean to go back. Sorry about that. So it's a short exam, but basically he has bilateral subepithelial lesions. I think his left side, if I remember right, is quite stiffer than the right. Let's take a look here.
And let's go a little higher than that. Higher.
So we took him to surgery, and I did a bilateral microflap excision, treated him with steroids at the same time as the surgery. Voice rest for 6 days, voice therapy, singing voice therapy. He was a little stiff on the left, so we did 2 local anesthesia subepithelial steroid injections for his recovery. And this is what he is like 5 months out. You can see his singing voice, singing VHI-10 is significantly improved, and this is what he sounds like.
Ooh.
And tell me how your voice was doing at the end of the tour and how things were going, both singing wise as well as speaking wise.
You know, still my speaking voice has more trouble than my singing voice. It just feels deeper and darker, but no one else seems to notice but me.
Great. And a little higher. Yeah. Good. Let's drop down lower. And higher again.
So hopefully you can get a sense that now he's got a straight edge, and most importantly, the pliability of his vocal folds has been significantly restored. He's done extremely well. This is probably 4, 5, 6 years ago. He's recorded several more albums. He goes out every summer and spends the whole summer making millions and millions of dollars, and lots of people are very happy because they like his music. So now we're going to transition to some surgical techniques. Here's some just overall principles, and a lot of these principles are discussed in great detail in the book. Ergonomics, decision making about surgery, consent about surgery, anesthesia for surgery. So there's lots of things that Dr. Simpson and I have added in the book to try to optimize your surgical practice. So I encourage you reading those chapters. And not just thinking because you heard this lecture, you're ready to start doing phonomicrosurgery. So the big question always is, what's my surgical approach? I've already told you I'm not a laser fan for this type of thing, so I'm fully kind of what we call cold steel. And then the 2 surgical approaches that are most commonly used in my hands are a microflap approach, which probably most of you I've heard about, and then a procedure that I call truncation. I don't know what other people call it. We don't hear about this in the literature very much. This technique is described in the book in great detail, and I'll show you a video and describe what truncation involves with. So let's talk about microflap first. The whole concept of microflap, which has been around for us for probably 20 plus years, is that we want to make an incision immediately lateral to the lesion, dissect the lesion out, preserve the normal overlying epithelium, and then lay the tissue back so we get healing by primary intention instead of healing by secondary intention. So I'm going to give you some of our artists' artwork to show you the steps of this surgical procedure. And so here's our artist's cartoon of a subepithelial cyst. The first approach is making an incision in the mucosa near the lesion. And I usually do that with a sickle knife. And you can put the sickle knife at 12 o'clock and then go through the mucosa and tent up that mucosa so you don't get anything deep and they don't pop the cyst as you do it. And then the hardest part of the whole operation is to elevate the mucosa off the underlying lesion. And you can see there's a small little elevator here. You'll see video of me doing this in just a couple minutes. And you want to work completely superficially before you work deep to the lesion. Once you've got this microflap completely elevated, like you see in frame D here, then you can take your curved elevator or some little dissector and go deep to the lesion. Which is usually generally quite easy for subepithelial pathology. The subepithelial component is the hardest, and that sometimes will take me 20, 30 minutes to do, taking your time not to pop the cyst as you do it. And then we remove the lesion. Often there's a little fibrous attachment anteriorly and posteriorly. It needs to be done before you lose the lesion. And then the most gratifying part of the whole operation is you redrape the flap. And often when you do this, you'll see a nice straight edge. And when you see that, you know your patient's going to have a high probability of having an excellent vocal recovery. This takes time, effort, training, and some specialized equipment. And I'll show you all of that in just a little bit. So here's an example from not our textbook because there's an error in this exam. Antonia, where's the error in this diagram?
Well, the incision is very lateral.
Correct. Correctly. Very well trained. And so there's no reason to make this incision as lateral as possible. So you want to make it as close to possible as to the lesion as possible, so you don't disturb the normal overlying mucosa and vibratory characteristics of the superior surface of the vocal fold. And so now, what do we do with this lesion? This lesion, it looks like a polyp to me, and I will tell you it is a polyp. And do we want to microflap to perform a microflap on this type of lesion? Antonia, would you do a microflap on this lesion?
You could attempt to do start with a microflap just to preserve the lamina propria, but in the end, you'll probably end up cutting the epithelium with the lesion.
Correct. Exactly. So I would not, you can use a microflap approach, especially it's very good practice, especially if you work with trainees. But in the end, this lesion has to come completely out with the overlying epithelium. This epithelium has been stretched out and is very abnormal. If you preserve this epithelium and you take that gelatinous material out of the polyp and you lay it all back, it will come back almost guaranteed. And so ultimately you want to remove this lesion completely. And I do not inject epinephrine or saline in this because I want to find and see this normal anatomic divide between the free edge and the pathology as I remove the lesion. And so here's a video of me doing truncation surgery on that exact same patient. And what you'll see in a minute is I'm going to grab the lesion with some triangular forceps, what some people will call a Boucher forceps. Oops, let's go back. I apologize. Here we go. And so I'm going to grab the lesion and provide some medial traction to that lesion. And once I've grabbed the lesion, my eye and my vision is all about the interface. Let's grab it first. It's easier said than done. So I'm looking at the interface between the free edge of the vocal fold and the lesion. And then this is a straight up scissors that I'm going to place one tine underneath and one tine below. and I'm going to take a nice straight cut and go right across the base. The number one concern or number one mistake for this operation is that you get into the lateral aspect of the vocal fold. You create a defect or a divot in the vocal fold. You don't want to ever do that. So you want to err on the side of being too superficial. And then you can suction away this little blood area here and see if there's any residual tissue, and take a small micro cup forceps and remove it. But you can see you've got a pretty nice straight edge here, and that's what you want. And so that's what I call a truncation procedure. And now let's talk about microflap for vocal fold cyst or fibrous mass. Again, we talked about these lesions can occur subepithelial or in the near or on the ligament. And so this is what this looks like. You saw this picture earlier. Here I've made the incision, I've dissected the microflap, and this subepithelial cyst is about to be removed. And here you can see the cyst has been removed and has been sent as being ready to send off to pathology. So here's a case of a lady who had a very large subepithelial cyst. So I just thought I would share with you her story and then also share with you her operative video to demonstrate what a microflap looks like. You can read for yourself. She's 38 years old. She's a former singer, mother of 3, has a very demanding voice job, and also coaches cheerleading, which is a really bad idea. And that her VHI-10 and her singing VHI-10 is very elevated. And here's what she sounds like, and here's her symptoms.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. How you heard that? I have nodules and I guess a lesion. Dr. Foreman, ENT, has forwarded me down here. I used to sing as a singer. It's gotten progressive.
I want to keep moving. She's a very complicated patient, as you're about to see, and I'm a little bit running out of time. So we're going to look at her examination.
Again.
So here she has a very large cyst of her left vocal fold, and she actually has a deeper lesion in her right vocal fold. I'll show you operatively what it looks like. So here she is just with a telescopic examination. You can see that large cyst of the left vocal fold, and then there's something deep going on in that right vocal fold that's much less obvious. I will tell you now, it turns out that that was a fibrous mass of the ligament of the right vocal fold. And then we're going to keep moving. So now this is the view through the microscope. And here I am palpating the lesion. What I'm doing here is I'm looking to see where's the lateral border of this lesion. Where can I make my incision without popping the cyst? And how deep does the lesion go? Does it go infraglottis and all those types of things? So now keep going here. So I've injected subepithelial epinephrine, and now this is me making an incision here with a sickle knife. I tend to put my sickle knife at 6 o'clock instead of 12 o'clock. And I'm trying to be as lateral as possible so I don't pop the cyst. And I'm just going to make that whole mucosal incision down here. And then we have the hard job of dissecting it out. So here you can see I have a small curved elevator. This curved elevator I developed with a company from Canada called Instrumentarium. This is called the Rosen elevator. If you're interested, you can get that from them. And so I'm working to take away this epithelium and get this lesion out. It's a very slow, tedious process. Usually I will work a little bit anteriorly, a little bit posteriorly, and then connect over time. Here, I'm going to speed this up here a little bit more. Peeling back the epithelium here, and now I'm starting to work around the aspect of that lesion. And now we're going to release this cyst anteriorly and posteriorly. And so we remove the fibrous attachments that attached anteriorly as well as posteriorly. And sometimes I'll take a pair of scissors and open up this space. I think this is what's happening now. So I'm spreading that area so you can see the posterior pole and the anterior pole. Sometimes this causes the cyst to pop right when you do that, but we're still pretty good space. So now we need to get this thing out. It's been freed and dissected superficially. It's been freed anteriorly and posteriorly. And now this is the dissection deep to the cyst. This is obviously superficial, but in a minute you'll say that seam curved elevator dissect deep to the lesion. At least I hope so. Again, that's opening up that anterior space, making sure it's free, opening up the posterior space, making sure there's nothing still hanging in there. And then we're going to work deep to the lesion. And now that's the dissection deep to the lesion. Seeing what's still hanging up. Okay, now let's take the lesion out.
I found this on the web for what's still hanging up.
And so often I like to find a little fibrous attachment close to the cyst and use that for some counter tension or some traction. So here's a small little micro alligator grasper. And now I can pull medially and start dissecting this lesion out. This is that Rosen elevator again, dissecting off the fibrous attachment, holding the cyst in place. All right. Now we're finally going to remove it. So now I've grabbed the entire cyst and I'm dissecting the final attachments off of the lesion. And as the lesion comes out, look at the edge of the vocal fold, and you'll see it's going to become really nice and straight right there. And that's, again, a very good prognostic sign. So I'm going to skip through that part, and then I'm going to skip through that, she had a different lesion. I didn't think it was right to do it at the same time, so I just did one side, let her recover, and then came back and did the other side. And so here's what she ended up, this is her summary of her whole thing. She had voice therapy, left microflap excision of a subepithelial cyst, which I just showed you, steroid injections to soften this and minimize scar tissue. And then she had a right microflap fibrous mass excision and a fat graft reconstruction because it was so deep and involved with some steroid injections after that, and then post-op voice therapy. So here's what she sounds like when she's all done.
The sunlight strikes raindrops in the air. They act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors.
Working the last steroid.
So let's look at our vocal folds.
Good, slow, please. Right back to it, please. Breathe a little higher. Yes.
All right. So you can see she's still a little stiff on the right side where that ligamentous lesion is, but she's got a straight edge and she's got good vibrating vocal folds. Typically, after phonomicrosurgery, like we've been talking about, it's 1 week of no talking, and then light voice use the second week, and then normal speaking, and then we don't usually like to do singing until about 30 days. And as you've heard, I often like to do steroid injections if there's severe stiffness postoperatively. Singing voice rehabilitation, if they're singers, is another important adjunct. So I'm moving as fast as I can so we don't run out of time. And so I'm going to just summarize and then we'll go to questions. And so hopefully you've got a sense of the concept of phonomicrosurgery as being precise microsurgery of the vocal folds. It can have great results, and patients really are happy to be able to have a functional, usable voice again. Vocal fold lesion nomenclature allows us to communicate with ourselves, with each other, with speech pathologists, with patients, and compare results helpfully. Maximum non-surgical treatment is really important. That's mostly voice therapy. And then there's a lot of technical detail with the surgery. Magnification, delicate instruments, as you saw, those are all really, really important. They are described in great detail in the textbook. If you love voice disorders and laryngology, I encourage you to come to Fall Voice Conference. It's the best clinical voice conference that I know of in the entire world. And it will happen this year in September in Denver, Colorado. So I invite you to join. It's a great 3 days of learning for almost everybody, speech language pathologists, as well as otolaryngologists and laryngologists. So if you have any questions, this is my email. This is also a QR code for the UCSF Voice and Swallowing Center. And I'm more than glad and excited to take any questions that are there.
Dr. Rosen, thank you very much for your presentation. It's very, very interesting how the techniques of phonomicrosurgery is very helpful for patients. Pero, doctora Antonia, no sé si, doctora Antonia, ¿está por allí?
Estoy acá, sí.
Sí, sí, doctora. Bueno, tenía muchas preguntas para el doctor, bueno, un par de preguntas, pero me generaron otras más. Y bueno, quería que me ayudara un poco a traducir esta inquietud que se me presentó durante la presentación del doctor,
Sí.
porque veía que los pacientes, al menos en los casos que presentó el doctor, antes de la operación, aparentemente tenían una voz que podía considerarse como que no tenía algún tipo de, o que no se escuchara. Ojo, estoy hablando desde el punto de vista no profesional. Y claro, después de la operación se veía realmente o se notaba una diferencia en la voz, pero ¿cómo llegan los pacientes a una consulta de voz? O sea, más allá de los cantantes, que son los que suelen tener esas, digamos, o percibir esas diferencias de voz, ¿cómo llegan los pacientes o cómo reconocen los pacientes o qué dicen los pacientes que reconocen cuando hay algo que no les está funcionando o creen que no les está funcionando en la voz?
Ya, lo voy a traducir para el doctor Rosen.
Ok.
So his question was that he saw a significant improvement in the voice outcomes after surgery, but he's saying that the preoperative voice was not that bad. So he's asking, how do patients notice this? What prompts them to go to your clinic? And
Yeah, it's a
ask.
good question. It's all about function. We don't really care. I never make a judgment on how somebody sounds. And when the consultation and the decision making regarding surgery or not surgery is all about function. Can they do what they need to do with their voice? And that's a very individualized and personalized question. The voice demands of a computer programmer are very, very different than a school teacher, singer, actor, TV reporter, and things like that. And so I usually like to frame everything into function. And so that's what brings people to my office. And that's what, thank you very much. I didn't get a chance to put the copy of the book in, so thank you. But it's all about function. And so that's what we focus on. That's one of the reasons we use the VHI-10, because the VHI-10 and other related patient-reported outcome measures have the sole responsibility or sole job or focus of quantifying the patient's voice handicap, the patient's own individual experience, and that's really what it's all about, in my opinion.
Bien, si ya entendieron la respuesta, se refiere a
Bueno,
que lo
podría, sí,
principal es la función, sí.
sí, básicamente es la función de la voz y de lo que quizás necesiten los pacientes para poder mejorar la voz, ¿no?
Sí,
Tenía otra pregunta. Bueno, el libro Técnicas quirúrgicas en laringología me llamó mucho la atención durante el proceso de edición, porque bueno, yo soy lingüista de profesión y cuando pues se hace alusión precisamente a la voz y al lenguaje, todo esto llama mi atención, ¿no? Quería yo saber cómo es el rol, o si hay realmente un rol en todo el proceso, de los terapistas del lenguaje en este proceso de recuperación de los pacientes.
okay, so he's asking what's the role of the SLP in the rehabilitation process.
Extremely important. If I can't say it enough, that you really need to be able to have a partner, a true partner with a speech pathologist who understands and is experienced in voice care work. Not all speech pathologists have that background, but it's really important. And lots of these patients do better. Don't need surgery at all, and voice therapy is almost always the first line of treatment. Even if it's a cyst or a polyp, it's obvious that you assume it's going to need surgery. We will usually try at least 1 or 2 sessions of voice therapy and see if they get better before we make the decision to have surgery. If they do need surgery, voice therapy beforehand and most importantly after makes there's a big job in helping the rehabilitation and especially preventing any new lesions to come after. A recurrence of benign lesions of the vocal fold are very rare if the patient has gone through voice therapy and is compliant, and most of the patients are generally very compliant because they don't want to ever go through this again.
Thank you. There are 2 questions from the audience as well. Procedo con esas preguntas, Félix?
Sí.
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 So one person is asking, what technique do you use to inject steroids into the vocal folds?
So at the end of each phonomicrosurgical procedure, most often I will inject steroids at the location of the surgical site, and that will usually be 10 milligram per cc concentration of Decadron, and I use a 27 gauge needle to inject the operative site. But if there is stiffness after surgery, 3 to 4 weeks after, then under local anesthesia, I have a 27 gauge needle that goes through the working channel of a flexible laryngoscope, and I'll use that to inject, again, Decadron 10 milligrams per cc concentration. Decadron is actually dexamethasone, the true chemical, so I should have used that instead of the trade name. And that's what I typically will inject 0.2, 0.3 cc's max, and I'll often do that 1, 2, 3 times about a month apart, right after surgery. If you let it go too long, the scar tissue forms, and the steroids won't make a difference. So I usually like to start the first steroid injection approximately 3 to 4 weeks after the procedure, and that first 2 or 3 months is the most important time to get the steroids in there to get the best results, in my opinion.
Thank
Doctora,
you.
no sé
¿La
si
traduzco?
pueda, sí
Lo,
puede repetir
redu-
un poco la
sí, lo
respuesta.
resumo.
Sí.
Lo que dijo es que cuando finaliza la cirugía, inyecta subepitelialmente con dexametasona en una concentración de 10 miligramos por ml con una aguja de 27G. Eso inyecta subepitelialmente directo a la zona operatoria. Luego, en el postoperatorio, si encuentra que la vibración de la cuerda vocal está un poco rígida, em, comienza una serie de inyecciones en la consulta ambulatoria con el paciente con anestesia tópica. Y esto lo hace con una aguja flexible que se introduce por el canal de trabajo del nasolaringoscopio, con dexametasona en la misma concentración de 10 miligramos por ml. Inyecta máximo 0,2 a 0,3 ml en cada cuerda de manera subepitelial. Y esto lo tiene que partir haciendo máximo 3 a 4 semanas después de la cirugía. y hace una inyección cada un mes aproximadamente, para un total de 3 inyecciones.
Ok, gracias, doctora. Bueno, hay otra pregunta allí, doctora.
The other question is if you use the same microflap technique for epidermal cysts that are small in patients that have not improved after voice therapy.
Yes, for
Maybe
sure. Yes, I would definitely use a microflap approach for any type of subepithelial pathology as long as the overlying epithelium is normal. So usually the answer is yes.
sí, dice que haría microflaps para cualquier patología subepitelial que tiene el epitelio sobre la lesión normal.
Bien, bien, doctora. Yo tengo otra pregunta adicional,
Sí.
tenía varias, pero viendo los casos, no sé si hay algún tipo de complicaciones que puedan surgir durante la cirugía de lesiones de las cuerdas vocales con el microflap y cómo podrían resolverse en caso de que haya posibles complicaciones.
Oh, okay. He's asking about complications associated to microflap surgery and how they could be solved or addressed.
The biggest concern or complication is scar tissue, where the vocal fold's stiff. Very, very rarely the microflap won't lay back down and epithelium will grow underneath that. I've only seen that twice in 30 years, but I've seen stiffness after the surgery for sure. And this is one of the reasons I don't use the laser, because I think the laser creates heat and causes more scar tissue. So that's why I'm a cold steel fan versus laser. To minimize scar tissue, I believe that steroids at the time of surgery are helpful, injecting, and then also not too much minimizing prolonged voice rest. So I think a week, 5 to 7 days of voice rest is needed or helpful, but not any longer. If it goes longer, I think the vocal folds start to stiffen up. So in general, I like to get things moving. And that's where, again, speech pathology after surgery is super helpful to get the voice, the vocal folds vibrating in a healthy manner and a voice used in a safe, effective manner. So those are the things that I usually try to avoid, try to use to prevent significant complication of scar tissue after surgery.
Will you inject steroids on every lesion that you remove or only like more deep lesions?
Typically the deep lesions. If it's just a truncation like that, truncation that I showed, I won't inject steroids. But if I'm dissecting a cyst out or a fibrous mass and I'm really inside the vocal fold and doing a lot of dissection, then I generally will.
Okay.
¿Podría traducirla, doctora? No sé si pueda resumir
La
un poquito.
respuesta, sí. Eh, dice que, bueno, la principal complicación asociada a esta cirugía en la cuerda vocal es la rigidez o como tejido cicatricial en la cuerda vocal y que para prevenirlo, lo primero, bueno, una correcta técnica quirúrgica. Se pueden inyectar corticoides en el momento operatorio cuando él se mete mucho en la cuerda vocal, es decir, cuando las lesiones son más profundas. Y bueno, hacer reposo vocal, pero no más de 7 días el reposo vocal, porque eso puede hacer que la cuerda se ponga más tiesa, que no empiece a vibrar correctamente, y iniciar la terapia de rehabilitación vocal con fonoaudiología después del 7.º día.
Bien, bien, doctora. Sí, hay una última pregunta, doctora. No sé si quiera leerla
Sí.
y sí.
There's one last question, which they are asking, what treatment will you do for bilateral vocal fold paralysis?
Oh, good question. It's in the book. So the textbook has a whole bunch of different surgical versions, surgical approaches. Transverse chordotomy, medial retinoidectomy, subtotal retinoidectomy, all done endoscopically. Those are the most common approaches that I use for bilateral vocal fold paralysis. If I remember right, there's also a laryngeal reinnervation component of the book, at least for superior laryngeal nerve reinnervation. But the most common techniques I use for bilateral vocal fold paralysis is a combination of transverse chordotomy and medial retinoidectomy. But the details of each one of those operations and how they all fit together is described in great detail in the book.
Thank you. Bueno, respondió que pueden leer el capítulo del libro que tiene todos los abordajes y la explicación. Él principalmente usa la cordotomía posterior asociada a una aritenoidectomía medial y también existen las otras técnicas de una aritenoidectomía más extendida o eventualmente también la reinervación laringea, que también dijo que puede que esté en el libro. Eso.
Bien, bien, doctores. Bueno, de verdad, muchísimas gracias por estar aquí hoy, doctora Lagos. Realmente fue de mucha ayuda en este proceso de traducción. Thank you, Dr. Rosen, for your time. It was an honor to have you with us today in this webinar. Dr. Rosen, would you like to add anything before we close the webinar?
Nope, I just wanted to thank again Antonia for giving her time and helping me with the translation of all of this, the book and the webinar. And thank you for the opportunity to share my thoughts. I really appreciate it.
Sí, bueno, un poco de problemas de audio, pero bueno, doctor Rosen, de verdad, fue un gran placer. It was a great pleasure to share with you today, and it's a beautiful book. It's the Spanish version of your of the book. Y bueno, doctora Lagos, de verdad, agradecido también nuevamente por su tiempo. Bueno, yo quiero decirles a los asistentes que hay una oferta disponible para el libro Técnicas quirúrgicas en laringología en la segunda edición. No sé si podamos poner allí el código QR para que los asistentes puedan tener más información al respecto. Y bueno, nada, no me queda más sino despedirme de nuevo. Muchísimas gracias a todos. Muchísimas gracias. Thank you, Dr. Rosen. Muchísimas gracias, doctora Aragos. Y bueno, ha sido un placer, de verdad. Que esté muy bien.
Gracias.
Bye bye. Bye, doctor.
Chao.